go ahead and get started. So I've met most of you here, but I'm Becky Powers, one of the new GREC staff physicians. And so today I'm going to be talking about Presbycusis. And I was kind of asked to step in at the last minute here, so I'm recycling a talk that I gave in fellowship. So Dr. Fisher may have actually heard a lot of this before, so I apologize for that. Okay, so before I really get started, I just wanted to put up one of my favorite quotes from Helen Keller that just kind of iterates how important deafness is in communication. And since this is a grand rounds that it was my understanding was supposed to target geriatric fellows and palliative care people, the communication aspect of it is actually really important as well when we start talking about hearing loss. And so the objectives of this talk, by the end of it, I want to make sure that we've talked about presbycusis, what it is, the epidemiology of it, and then the different effects, so what it sounds like to somebody who has it. And then go into a little bit of the basic physiology of hearing, so we can understand what goes wrong with age-related changes, and how that can cause the symptoms that people with presbycusis have. And so, literally, presbycusis means old age hearing when you break it down from the Latin. And it's the most common hearing loss that people have over the age of 50. And I'm kind of using it as a catch-all term for any sort of sensory neural loss that happens when somebody is older. And it's not attributable to any other major pathologic reason that they're having hearing loss. And it can result from a lifetime of insults to the auditory system. There are lots of different things that can cause hearing loss. Loud noises, different medications that we give, systemic diseases, genetic problems, and then basic hearing, ear issues as well. And so when somebody has presbycusis, one of the most common things that you'll hear them say is, "I can hear you, but I can't understand you," because speech understanding is very impaired when somebody has this age-related hearing loss. They have reduced sensitivity, so they aren't able to hear sounds, and this is mostly in the high frequencies. They have a lot of trouble in hearing in noise, so any kind of background noise is going to be very troublesome for them, more so than somebody with good hearing, even though most of us have a hard time hearing in noise anyway. They also have problems with impaired sound detection and localization, so just being able to hear where things are coming from. And they have a slowed processing centrally of auditory information. And so hopefully as we go through some of the pathophysiology here, you'll understand why that occurs. And one of the reasons that I'm interested in this is because it's very common. The World Health Organization estimates that about 500 million people across the world have hearing loss, age-related hearing loss. And to make it a little bit more specific to America, NHANES found that 63% of people over the age of 70 have some sort of hearing loss, and almost 30% of those have moderate to severe loss. And the Framingham findings on hearing loss also back that up, as do a lot of other nationally representative surveys. But I'm more of a visual person, and so this graph really is what strikes me. You can see with every decile in age, the population with hearing loss is basically doubling. And this is just looking from NHANES data from people with bilateral sensory neural hearing loss. So when they get to the over 80 age group, almost 80% of them are going to have bilateral loss. If you look at just the unilateral loss, you're hitting about 90% of people will have hearing loss. So when you kind of look at the numbers on this chart, when you're talking about the geriatric population, it's almost safer to assume that they have hearing loss than that they don't when you're trying to communicate with them. And to kind of understand hearing loss a little bit better, I wanted to throw in a little bit about how it's measured, because a couple of weeks ago we had a journal club looking at one of the articles relating hearing loss to exercise in older adults. And there were some questions that came up about what the different measurements of hearing loss meant. And so this is an audiogram, which is what the audiologists are going to measure hearing loss on and put down all their findings. And so this is basically just a graph where on the x-axis you have the pitches or frequencies going from very low-pitched sounds to very high-pitched sounds. And on the y-axis you have the loudness measured in decibels. From very soft sounds to very loud sounds. And so you can plot out the different frequencies where someone can hear and how loud something has to be for them to be able to hear at that frequency. And on this particular audiogram, the different demarcations are where the World Health Organization has defined the different levels of hearing loss. There are several different organizations that have defined the cutoffs. So ASHA, which is the Society of Audiologists, has a slightly different classification. But again, just because I wanted to give this talk related to the journal club we had earlier, I chose the World Health Organization ones on here because that's what they were using in that paper. And so when you're looking at an audiogram, this is what normal hearing would look like. And if most of us have probably had a hearing test at some point in our life where they put you in the booth, put the headphones on or the earphones in, and they play different tones and ask you to raise your hand if you've heard the tone. So the audiogram is what they're generating there. They're playing tones at different frequencies, and so they're trying to figure out at what loudness level you can hear that tone 50% of the time, and that's considered your threshold. So they'll mark down the threshold there. So for example, this person was able to hear the sound at 1,000 hertz at 0 decibels in both ears, and so they were marking that down. And you may wonder why it can go to -10 decibels, and that's because this is really rated for 0 being what someone with normal hearing as a young child would be able to hear. And so there are some people who can hear a little bit better than normal, and that's why you can get to -10. Now, if somebody's in the -10 range all the way down, it can cause some problems as well, because they can start hearing things like blood rushing through their ears and causing other problems too. But anything, this is not actually using the World Health Organization cutoff, anything less than 25 decibels is considered normal across the span. And as you're interpreting these for your patients, there's a convention where the right ear is always going to be red and round. So remember, all the R's go together, so if you're seeing a non-color picture, you know what ear everything's referring to. But we're not talking about normal hearing, we're talking about presbycusis. And so this is what the typical audiogram would look like for somebody who has presbycusis. So you can see that the high frequencies are, they're having a lot of difficulty there, and they need a louder sound just to be able to pick it up. And so anything on the audiogram that would fall above that slope, they're not going to be able to hear if it's in one of the frequencies and a loudness level that falls above those lines. And one way to talk about this without having to show an entire audiogram is to talk about pure tone averages, where they basically will take the loudness level that you can hear, 3 different frequencies, and average them together, and that'll give you an understanding of how well the person can hear overall. Now, the paper that we were looking at a couple of weeks ago, I also threw in the 4,000 hertz frequency because that's very important for speech understanding, so they averaged 4 together. And so that's what they were using. So I kind of just showed you, even though this is a steeply sloping curve, the pure tone average kind of gives you a number in the middle to get a better understanding of where somebody's hearing loss is. And so I also like to show this graph that's called the speech banana, because it puts on the audiogram where different common sounds are that you hear, because to me, I don't understand what, 2,000 hertz at 50 decibels, what that would really be. And so you can see, like, whispering is going to be a very high frequency soft sound, but like the ambulance siren, a very high frequency loud sound. And the common sounds for speech fall in that area that looks kind of like a banana, which is why they call it that. And so if you can remember where those lines were for the common presbycusis audiogram, it's cutting right through the center of the speech banana. And it's cutting off the consonants, basically. And the consonants, when you think about it, are what give meaning to speech. And so when you're talking to somebody, if they can't tell the difference between F, S, and TH as sounds, because those are going to be the highest frequency, softest sounds, they're not going to know if you said fat, sat, that, without looking at you and possibly lip reading, or they even still may not be able to do that. And so it's going to be just something to be mindful of when you're communicating with somebody who may have some hearing loss. And so when we're getting back to presbycusis and how it evolves, the first part of it is going to be this high tone hearing loss that's worse in noisy situations. But as things progress, you wind up having more difficulty localizing sounds, which can be safety concerns as well when you think about what that would play out with in real life. And then you wind up having effects as things get worse. It's going to be affecting the 2 to 4 kilohertz range, which is really where a lot of the meaning for speech comes in. And so you're going to have a hard time with communication with these people. And so this can just kind of lead to a phenotype of someone who has a lot of word confusion. They don't understand exactly what you're saying. And they're going to be missing high-frequency warning sounds, because when you think about it, most of the warning alerts in our life are very high-frequency, high-pitched. They might not be able to hear the smoke detector. So we may be talking to our possibly demented patient, asking them, what would you do when you hear the fire alarm? But we're not really thinking, oh, they may not be able to hear the fire alarm. So coming up with safety plans, you need to kind of take hearing loss into account. And then, like the journal club we had a couple of weeks ago, there have been a lot of epidemiologic studies that are starting to link hearing loss with psychosocial effects, emotional effects, cognitive, and even physical problems. And so having a better understanding of hearing loss will be able to hopefully help us take care of our patients a little bit better. But all of these things being said, what's really happening in the ear of somebody who is older? What's causing all of this to happen? So if you'll bear with me, I'm going to take you through some netter diagrams to describe how we hear, and then hopefully that can help us understand what goes wrong and why that's happening with aging. And so I'm just going to work from the outer ear to the middle ear to the inner ear on this. And so sound waves, that's really mechanical energy that's going through the air, and it's being picked up through the outer ear. So the reason that our ear is shaped so strangely, I mean, if you've ever taken a second to look at an ear, it looks very odd. And so it's basically mechanically optimized to pick up sounds to help with detection, and also as it funnels down into the ear canal, it is amplifying those sounds to get to the tympanic membrane. And so in the outer ear, those are really the main structures, and there's not as much that can go wrong there. But there are age-related changes that happen in the outer ear. So a lot of this is going to be related to the elastic fibers and collagen in the ear are going to degrade over time. The pinna is going to change in size, which can lead to those localization problems because it's no longer optimized for picking up sounds. And the thinning and atrophy of the skin and subcutaneous tissues, as well as decreased sebaceous glands, are going to lead to dry skin that can break easily, which is going to be a problem when you're trying to put hearing aids in, and could be part of the compliance issues that we wind up seeing for that. And also, cerumen gland secretion, it kind of dries up as well. And so this makes the cerumen much more hard, and that in combination with the increased hair growth is why we see a lot of cerumen impaction, which can really impair hearing as well, as much as almost 10 decibels per frequency when somebody has a cerumen impaction. And so, that being said about the outer ear, moving to the middle ear, we've got the sound waves coming through and vibrating the tympanic membrane. And so what the inner ear is doing is really trying to help amplify those sounds to get it, or the mechanical waves of the sounds, to get it to the cochlea. And so for that we have the eustachian tube, and the whole purpose of the eustachian tube is to keep the middle ear open to the air, and so that way it can normalize pressure across the tympanic membrane, allowing it to vibrate freely. And so once it's vibrating, it starts to vibrate the 3 small bones of the ear, and those serve to help amplify the sound waves until they get to the oval window, which is attached to the cochlea. And so as the sound is going through and vibrating, it amplifies it almost 17 times for the of the mechanical waves, and that's going to be very important once we get to the inner ear for how it actually works and transfers that mechanical energy into electrical and chemical energy to get it to the brain. And so changes that can happen in the inner ear, again, not quite as important for presbycusis, but we can have stiffening and thinning and loss of vascularity of the tympanic membrane, so it's not going to vibrate as well. Arthritic changes in the joints of the small bones, so again, not vibrating as well. Atrophy and degeneration of the fibers of the inner ear and the ligaments that hold the bones in place, and then increased calcification. of the ossicles and also of the eustachian tubes. So basically everything just might not move as well, and this is going to lead to more of a conductive type loss, but not necessarily presbycusis. And so again, the outer and middle ear are important for getting the sound to the cochlea, but and they're important for making sure somebody can actually wear their hearing aids, but not necessarily as important for the pathology that's going on with presbycusis and the sensory neural aspects of it. And so where things really start to get interesting is the inner ear. And here it starts with the cochlea. So the sound's already hit the oval window, and it's vibrating that at 17 times higher magnitude than it was when it came in. And it starts to vibrate through the fluid-filled cochlea, which is actually about 2.5 centimeters in length, and it's wound up just to preserve space. The winding of it doesn't have anything to do with its function. And so inside the cochlea, if we take a cross-section of it, we've got 3 fluid-filled compartments. And so we've got the scala vestibuli and the scala tympani, which are full of perilymph, which is a sodium-rich solution similar to the inside of cells. And then we have the scala media, which is full of endolymph, which is a potassium-rich fluid. And the scala media is what's important, or scala vascularis is what is important for maintaining that gradient. And as the stria vascularis' name implies, it's actually a very vascular structure. It's microvascular, which is going to hint at some of the problems that come along that cause presbycusis. And so the blood flow through that is really what's feeding the rest of the cochlea and keeping the metabolic gradient in place to be able to convert the mechanical energy to electrical energy. And so when we blow that up even more, we can see the organ of Corti, which is the main organ for sensory pickup in the ear. And so this is made up of a lot of support cells. So you can see pillar cells, Henson cells, Dieter cells that are there just to keep it, the shape that it needs to be able to work properly. And then we have outer hair cells and inner hair cells. And these are lined up along the basilar membrane. And when you look at that wound up picture of the cochlea, the basilar membrane is spanning the entire area of the cochlea. So that blue line that's going through is really where the basilar membrane is going to be. And the outer hair cells are what they call tonotopically organized, meaning that all along it, they go from very high frequencies by the oval window to the very low frequencies towards the center of the cochlea. And it's kind of just like a big pipe organ, if you want to think about it that way. And so as the basilar membrane is vibrating, it's picking up different frequencies. So when the round window starts to vibrate, the basilar membrane is going to vibrate too, because it's in a very fluid-rich area. And the outer hair cells are sitting on that. They're going to start to vibrate as well. And if you can remember a little bit about harmonics from physics, if you can pull back to that, when something is vibrating and you hit the right harmonic, it's going to amplify how much it can vibrate. And the harmonics that are right next to it, if it's not lining up, it's going to diminish the vibrations on that. So what the outer hair cells' jobs are to pick up the right harmonic, and they're going to vibrate a lot when you have a tone that's played that they're tuned to. When they vibrate, their stereocilia are embedded in the tectorial membrane, and so that's going to start to vibrate even more, and that amplified vibration is what's going to allow the inner hair cells to vibrate. And when the inner hair cell finally starts to vibrate, that's what shoots off the impulse to the brain to allow it to understand that a sound has been made. So hopefully I didn't bore you too much, but just to kind of get that basic understanding of how it works, because it's a very complex system, you can start to understand the 6 different types of presbycusis and what's going wrong there. So basically it just, the 6 main types of presbycusis target different areas in the cochlea and what can go wrong in the aging process. So the first one is sensory type presbycusis, and this is when there are problems with the outer hair cells, which are the ones that are helping us pick what sound is actually being played. So when there's a problem with the outer hair cell, you're not going to be able to pick up the frequency, and you're not going to be as sensitive to sounds. And so there's also loss of organ of Corti, the support cells in the organ of Corti, and so those are basically there to support the outer hair cells and allow them to stretch and bend the way they need to. And when those go, you have hearing loss as well. And this tends to start by the oval window, so they start with the very high frequencies and move to the lower frequencies kind of in order. And you don't really see hearing loss from this type until it hits the frequencies that are important for speech. And so things that can happen to cause this atrophy of the outer hair cells are not necessarily age-related, but they can compound as age progresses. So noise trauma is one of the things that really hurts the outer hair cells. Basically, it shears the cilia off of the tectorial membrane, so they can't vibrate and cause and get the impulses to generate to the brain. When this happens, there's free radical production as well that can injure other aspects of the cochlea. There's some genetics that have been linked to this. The AHL gene just stands for age-related hearing loss gene, and it's been shown to be linked to problems with outer hair cells, but it's still unclear on exactly how that works. And then there are different ototoxic medications, some of which we know how they're ototoxic and some we don't. Free radical damage is a big part of it, and then hydrostatic pressure is another part. And so aspirin is a big culprit for this, and that's why it can have reversible hearing loss, because the outer hair cells are very attuned to hydrostatic pressure. They need it because as they can either shrink or grow, and that's how they can transmit the loudness of a sound down. And when aspirin comes into play, it shrinks them too much, and they are not able to work at all. And this is why, but once the aspirin is out of the system, it can go back to its normal shape. And so that's part of the reason that aspirin is reversible. Now, we don't know why furosemide or NSAIDs cause hearing loss. We could have a long talk about just ototoxic medications, but they are linked with hearing loss as well and damage to the outer hair cells. And so when somebody has sensory presbycusis, linking it back to what we see, you can see this high frequency slope on the audiogram as well, but they'll have pretty good speech discrimination as long as the slope doesn't hit the part of the frequencies that are required for speech understanding. But then we have neuronal type presbycusis. So this is when something goes wrong with the nerves. And this system is very highly tuned, and so basically we're born with 35,000 cochlear neurons, and about every 10 years we lose 2,000 of them. And it's very diffuse on where this happens. And once we have lost about 50% of those neurons, you're going to notice hearing loss. And so that means once you hit about your 8th decade, which is where we see the big spike, you're going to have hearing loss. And so with this, people are going to have poorer than expected word recognition, and that's all related to the fact that once the nerve is gone, they're not able to understand the sound as well. And so it's, again, very diffuse, so you're going to have the high frequency losses that may be attributed to other types of presbycusis, but it's really that low word recognition that's attributed to the nerves. And so then the strial type presbycusis is really kind of where the money is. That's where the most common area for damage is to cause hearing loss. And this is all due to the microvascular changes that lead to metabolic problems. And so the strial cells are basically lost in the apical, which is the low pitch area, or the middle pitch areas. But it doesn't really matter where they're lost because they're what's responsible for generating that gradient. And as long as the gradient is not as strong for sodium and potassium, it's not going to be able to generate the signals as strongly. And so once you have about 30% damage, it's going to mess up that gradient, and then you're going to wind up having kind of a flat hearing loss because it doesn't matter what pitch it is if you're not able to generate the proper gradient to move that sound down to the nerve. And so, as you can imagine, anything that causes microvascular disease could be linked to this type of hearing loss. And that's why, like in the article that we looked at a couple of weeks ago, we saw that the only things they wanted to control for were cardiovascular type problems like diabetes and heart disease and hypertension, stroke, things like that. So there's a fairly well-known link between hearing loss and any of those microvascular diseases. And this is just an example of the flat audiogram you're going to see for somebody that has this type of hearing loss. But they'll have pretty good speech discrimination still because it's not really affecting the nerve. It's once the nerve fires, it's still good and intact. It's just harder to get it to fire. Then there's a mechanical type presbycusis. And so this is more theoretical. Most of the work that's been done to try to understand presbycusis has been done very recently just because it's the cochlea is such a small object that's in one of the hardest bones of the body, and so it's very hard to get in and see it, and there's really not a way to look at it while it's in action. So that's why this is still just theoretical of a loss of elasticity of the basilar membrane or anything that allows the vibrations could be causing this mechanical type of loss. And so on this, it's basically just saying that if you have a loss of more than 50 decibels between your best threshold and your worst threshold, it might be this mechanical type presbycusis. And then there's mixed, which is fairly self-explanatory. You can have more than one of these going on at a time. And the loss on this appears to be additive. And intermediate is basically just saying you could have any of these mechanisms going on, but not to the degree to really call it one or the other. And there could be submicroscopic alterations going on in the cochlea as well that's just interfering with these processes. And it's going to be hard to predict what this audiogram is going to look like too. And so basically, all of that to say that the main age-related changes in presbycusis are related to atrophy and degeneration of the different parts of the cochlea and the loss in number of function of nerves in the cochlea as well. But there are lots of other things that can go wrong because when you think about the chain of how things have to move through the brain to be able to understand and interpret sounds, we only got to the inner ear or cochlear nerve on this chain, and there are lots of other processes that may wind up having pathologies in them causing what we call central presbycusis, which is kind of a new theory, and it's not as well understood just because a lot of brain science is not very well understood right now. So don't know exactly where things are going wrong there. But kind of the main tenet of this idea of central presbycusis is that while there are degenerative changes going on in the brain, there are also degenerative changes going on in the ear, and all of that can lead to slower processing abilities and poor speech recognition. And the poor speech recognition and cognition can play back and forth on each other just to make it look worse. And in that same vein, just to kind of summarize what we were seeing here for presbycusis, just have kind of a diagram to talk about all of it. And so we kind of talked about it like it's all different separate processes that are going on, that we may have a vascular issue or a sensory issue, a mechanical issue, a nerve issue, or a central issue, but really it's more of a continuum and it all works together. And so kind of right now the working theory is that you get degeneration in the stria vascularis from these microvascular changes that lead to problems with the endolymph and the action potential that it can generate. And then that leads to problems with the inner hair cell activity and activity in the auditory nerve and activity in the brain, and that it's all kind of linked together. And again, to kind of make it even more global, and one of the reasons that I wanted to talk about this now, after having that journal club, was there's this theory that we found that hearing loss is actually linked to cognitive and physical functioning. But we don't know why. We don't know if it's a common cause or if it's a modifiable risk factor. And so understanding that could be one way to try to help improve aging and aging health, or healthy aging. And so basically, if it's a common pathological process, then it's some sort of not understood thing that's acting and causing you to both have cognitive and physical functioning declines and hearing loss, all in the same syndrome. Or it could be targets to actually help treat decreased cognitive and physical functioning with aging by targeting things like cognitive load, meaning if we amplify somebody's hearing loss, then they're not having to focus on hearing you and what you said. They only have to focus on the task of what you said. And so in that way you're decreasing their cognitive load. Or if we find some sort of target in brain structure and function, then working to target that may also help improve the cognitive and physical functioning. Or if we target the social isolation that comes with hearing loss, because people tend to pull to themselves and isolate when they can't understand what's going on around them. And so just kind of understanding more about hearing loss in older adults may be able to help us understand more about healthy aging as well. And so hopefully now people understand a little bit more about what presbycusis is, how common it is, and then kind of the basic mechanisms of why it happens. So are there any questions? Yes.
So, why is it the high frequency seems to really take it on the chin compared to the other frequencies?
And from what I've been able to see, it has to do with that tonotopic organization. And so they're the ones that are closest to the oval window in the cochlea, and so they're going to take the hits first before the low frequencies are. And it's just kind of unfortunate that that's where a lot of the speech understanding winds up having to be.
You know, the frequency audiogram is logarithmically scaled. So you're doubling every time you go out. Is human hearing equally scaled, or is it becoming less sensitive as it goes out? In other words, at the left side, you could have a difference between 250 and 500 hertz. And on the right, it would be 4,000 to 8,000.
Yes.
So can a human distinguish 4,000 from 425?
So it's my understanding that you can distinguish between like 5% of a sound, because when you think about it, I forget the exact frequency rate of things like piano notes, but like middle C is like 256, and one octave above that is 516, but you can still hear the 12 notes in between it and really distinguish. So when it gets to the higher frequencies, I'm not sure if that relationship still holds true, but that's definitely something I need to look into more.
For like hearing aids, do they take into account what kind of hearing loss you have as
Yes.
to what type of hearing aid? Because see, to me, a hearing aid is a hearing aid. I don't know
Exactly.
if there's different kinds or okay.
Yeah, and so the reason that the audiologist will go through and map out the hearing like that is because hearing aids can selectively amplify the different frequencies to give you more of a boost in wherever your loss is. They do a lot more testing than just the audiogram, but I didn't want to really get into that because it wasn't the focus of the talk today. But they can also do speech and noise testing and figure out your word recognition score, so what percent of speech can you recognize, and how loud does speech need to be before you can recognize it. And they can use all of that to help program the hearing aids. They also have tests where they can put probes behind the hearing aid in the ear to take into account the structure of the ear canal and make sure that all the vibrations for your unique hearing canal structure are being programmed appropriately into the hearing aids.
Any more questions? Additional questions? Okay, well, thank you very much for the presentation. Thank you so much. Don't forget to sign in for Howard's evaluation today. It'll be in your inbox. And then stay tuned for other emails about the next plan round. For other emails about the notifications for records. I get that a lot. I get that a lot.
Stop working this morning.
That's a joke. I had to call the help desk. They were like, you've been locked out and you're good now. But I don't understand that consistent issues going on.
Maybe we clicked on one of those email links.